Bismillahirrahmanirrahim. My dear students, Assalamu alaikum. Today we are going to discuss the cataract in our third lecture. Subject title is cataract surgery. We have done with detailed of cataract discussion, its presentation, its clinical evaluation, laboratory investigations, pre-operative assessment and management, and now we are going to start the discussion on cataract surgery. So let me tell you that cataract surgery is the most common operation performed all over the world beyond the age of 60 years, and more than 95% operations are successful with good quality of post-operative vision. Presently, we can do even better visual activity and visual assessment after surgery, many times removing other problems that were existing before surgery like astigmatism, monocularity, by using toric as well as multifocal intraocular lens implants. So, the learning objectives of today that we should know various cataract surgical techniques and gadgetry involved and indications for cataract surgery at the present time. We should also know the complications that can occur during or after cataract surgery and how to manage them. Today, the tutorial is meant primarily for this purpose, and if the time allows and situation improves, we will do the same in case discussions in OPD, wards or operation theatre. Meanwhile, you are free to discuss with me at your WhatsApp group and Facebook and individually. All these cases or anything in relation to cataract surgery with me at any time I am available. Now, before going to details of surgery, we should know some basic things like the types of intraocular lens implants to be implanted in the eye at the time of surgery. Basically, there are two types of lens implants: rigid and foldable. The rigid IOL implants are made up of polymethyl methacrylate, which is a typical plastic material of high quality, rigid and cannot be molded or folded. The foldable lens implants are made up of acrylic material, which is foldable and can be injected through a small incision. Its shape is like this. Central area is known as optic for vision. It is present in the pupillary area, and haptics, they are fixed in the capsular bag in case of foldable IOL implants. And rigid implants are of two types, as I have told, made up of PMA material. There may be rigid posterior chamber IOL implant or rigid anterior chamber IOL implant. Posterior one resembles that of foldable in its shape. It has central optic, and these two are haptic. Optic is basically visual area of the lens in which the refractive power exists. It is placed in the center of the capsular bag on the back of pupil in front of and posterior capsule of the lens. And these haptics, they are fixed here in case of extracapsular cataract extraction in the ciliary sulcus. Whereas look at this right one, this is anterior chamber rigid IOL implant. Again, it has a optic in the center. This optic is placed in front of pupil here in this case because it is placed in anterior chamber, not in posterior chamber. Its haptics are more curved and have double curve, and that is fixed in the angle of anterior chamber to stabilize the intraocular lens implant. We will go into detail further in the next slides to come. Now, how to differentiate between various surgical techniques of cataract. The previous or old-timer intracapsular cataract extraction, the one, the extracapsular cataract extraction, and the present most commonly used surgery is the PHACOEMULSIFICATIon. So just let me tell you differences between two that you can understand what are the various types. PHACOEMULSIFICATIon is also a high quality extracapsular cataract extraction, which I will tell you later. What is intracapsular cataract extraction, ICCE? Here look at this diagram. We make an incision in the cornea up to 8 to 10 millimeter, just like this one. Destabilize the zonules of the lens by some maneuvering around that, and then we pass a probe with a tip like this. See this diagram. This is a probe for intracapsular cataract extraction. It is at very low temperature of minus 80 degrees centigrade, and it makes an ice bulb at the end that is attached to the lens anterior capsule, and then it adheres to it strongly and it is pulled out simply out from the wound. Complete lens along with capsule is taken out, and remaining portion has no part of lens, only anti-highlight face of vitreous is there. This is intracapsular cataract extraction. Now what is extracapsular extraction? Come at this right diagram. Here we make again 6 to 8 millimeter incision at the limbus, and then remove the nucleus. After making capsulotomy in the anterior capsule, here we remove the nucleus, hard nucleus, through this wound, and then remove the cortex with the Simcoe cannula or two-way irrigation aspiration cannula of the phaco tip. So this is the way. And how you recognize this was a case of extracapsular cataract extraction? Look at the diagram here. You can see sutures. Sutures are applied only in case of intracapsular and extracapsular cataract extraction. Now third one is PHACOEMULSIFICATIon. Look at the center diagram. We make a very small incision of 2 to 2.5 millimeter in the limbus or peripheral corneal area with the phaco knife. Then make a capsulotomy in the anterior capsule, and with the help of this phaco tip, this has a very high power electronic ultrasonic machine that vibrates. This vibrator disrupts the lens nucleus into many pieces, and then they can be sucked. So no need to remove this big lens from a wound. All pieces are sucked out from this tip, and then lens is injected through this tip into this capsular bag within the bag. This is a diagram. See just underneath. This is a diagram or photo of the patient after phaco surgery. You are seeing a very well formed pupil after surgery, lens in the bag, and no suture here. This is the way you differentiate three types of cataract surgeries. Now coming into detail of individual surgery, intracapsular cataract extraction. Now look at this. A very big incision is made about say 10 millimeter at the limbus. Then the cornea is lifted by suture like this, and this is iris repositor. Iris is pushed back, and lens bulges forward. Here, the frozen tip of the probe is attached to this lens. It gets adherent to lens, and whole lens is taken out. This is intracapsular cataract extraction. Then this is followed by implantation of anterior chamber lens implant. See in this diagram after surgery, the lens was taken out and blocked with all its elements, followed by placement of this anterior chamber lens implant. इसका कैसे पता चलता है कि anterior chamber है? You can see pupil on the back of the lens, and you can see this optic as well as haptics. Haptics are fixed in the angle of anterior chamber on both sides. Now there occurs a problem in it that we have blurred the pupil, so there will be no aqueous drainage from posterior chamber to anterior chamber, and the patient can fall into acute congestive glaucoma. To prevent that complication, we make a hole at the peripheral of the iris known as peripheral iridectomy like this, through which aqueous drains directly from posterior chamber into anterior chamber and then to the ankle anterior chamber, from where it drains into the trabecular meshwork. So it is mandatory part of intracapsular cataract extraction. So whenever you write treatment of some cataract as intracapsular cataract extraction, always write this: intracapsular cataract extraction plus IOL implant plus PI. PI stands for peripheral iridectomy. Otherwise, it will not be a complete operation. Now, what is extracapsular cataract extraction? What we do here, in first step, look here, we make a very small, about less than 1 millimeter wound at the limbus and pass this cystotome. I will show in detail later. The cystotome is passed through this and make a can opening in the anterior capsule known as can opening anterior capsulotomy. So here it is complete. Now we are opened it completely just like can opening, and next step we expulse the nucleus from it. Nucleus is taken out. Prior to that, incision was enlarged with corner scissors to say 8 to 10 millimeter, and remaining cortical material is washed by either this phaco tip, irrigation aspiration cannula, or Simcoe irrigation aspiration cannula. After the surgery, you can see this patient. Good surgery, good pupil, lens on the back of the pupil, jet black pupil, typical of pseudophakic pupil. But you are seeing sutures here 1, 2, 3, 4, 5, 6. 4 to 5 or 6 sutures applied depending upon the size of the lens aspirated. Okay, so you will always see sutures in case of extracapsular and intracapsular lens. In extracapsular, you will not see lens in front of iris. In intracapsular, that will be in front of iris. Now, PHACOEMULSIFICATION, the latest surgical technique. Just see some instruments we use in PHACOEMULSIFICATION. See here in upper left, this is a phaco knife, triangular knife. Here it is magnification, very sharp knife with size ranging from 2 to 2.75 or even 3 millimeter in its diameter. Very sharp cutting and makes a very fine cut in the cornea or limbus at the periphery. Once this is done, we fill the antechamber with viscoelastic gel, and then with the help of this capsulotome or cystotome, दो नाम है इसके, capsulotome भी कहते हैं, cystotome भी कहते हैं. With this is a curve we make it ourselves with the insulin needle like this, one curve and other fine curve at the tip. This curve is cutting. With this we make capsular opening, maybe it can opening for extracapsular or CCC for PHACOEMULSIFICATIon, and after that we use this hydrodissection cannula, this one. Its tip is flat and we pass balanced solution from syringe attached to it, that is passed. That syringe is passed through it and we give a gush of fluid from it between the capsule and the rest of the lens, as you will see in the coming videos, and that will dissect away the lens from the capsule and we can easily do PHACOEMULSIFICATIon later. Now see these videos. Here, this is phaco knife. You can see in our setup, you will see with this pink color. In this diagram, you are seeing two instruments. One is corner scissor, sharp one, and blunt one is the needle holder, corner needle holder for suturing. This diagram, lower one, you are seeing cystotome. Insulin से बनाई गई आगे typical tip I had told you and seen in the diagram. This will be maybe present in your OSCE examination. Now, other instruments include Simcoe irrigation aspiration cannula, bimanual, a golden head, and another silver head. The golden head is the one with which we attach balanced solution through a drip infusion, and it passes and keeps the anterior chamber of eye filled with balanced solution. Here it is magnification. You can see two ends of this. This bigger one is to suck cortical material from the lens, and this small one is to hydrate, to fill the anterior chamber of the eye all the time during surgery so that cornea is not pushed back. Here this is another golden, this silver end. Here we attach a syringe of 10 cc and we suck this cortical lens matter in case of cataract surgery with this, and sometimes blood or exudates if they are present in the eye due to another reason. So mind, it has two ends, this one, and again this has two parts. One is for irrigation, जहाँ से fluid जाता है, और इससे जो हम this one we suck it from this passes through this tubing, and here we have attached the syringe and we suck it manually the lens matter, soft lens matter of cortex or exudates or hemorrhage of blood in the eye through this cannula. Okay, so this is bimanual Simcoe irrigation aspiration cannula. दाएं हाथ में इसको पकड़ते हैं और बाएं हाथ से इसको सक करते हैं यहाँ से. Similar principle is that of phaco tip. The tip of PHACOEMULSIFICATION machine, it has this hole. There are two on the both sides. They are for irrigation. यहाँ से fluid बहुत high flow से आता है from attached to a drip over, and this fluid keeps the anterior chamber maintained during surgery. And this is phaco tip. From here we do many things. It has a cutter, that is PHACOEMULSIFYING cutter, ultrasonic machine inside it with its tip that keep vibrating at very high frequency, and it disintegrates the lens hard nucleus into small pieces, and then it itself sucks it through a vacuum created in the machine, and that entire material is taken without enlarging the size of the LCM. So this is the PHACOEMULSIFICATIon tip. This may also be seen and shown to you in OSCE, so you should remember it. Now details of phaco. आप देखिए इसमें क्या है. First step, we make an incision, small 2 mm incision with a sharp this phaco knife or diamond knife here. Then you do cystotome. With the help of cystotome we do capsulotomy. We started here. एक incision छोटा सा दिया था for entry of this wound, and the second incision is for capsulotomy here. From there capsulotomy is being done, being enlarged here and completed here, and after that this is the diagrammatic representation. This blue is the iris on the back of cornea. This gray is the anterior capsule. Here is the capsulorhexis edge. Central calvinular capsulorhexis or central circular capsulorhexis is done with cystosome here, and this is the edge of this anterior capsule anteriorly and lens within that. So this is being hydration done, hydrodissection. ये करने के बाद hydrodissection tip is passed between this anterior capsular edge and the lens, like here, and fluid is pushed through it. It dissects out all this lens parts from the capsule, and lens is free within it. Then with the help of phaco tip here, we disintegrate the lens nucleus into various parts, and then they are sucked out, and that is followed by implantation of intraocular lens, which is injected here. This is the sequence of events in PHACOEMULSIFICATIon. This is a video you see for PHACOEMULSIFICATIon. Just sideboard incisions, then main incision. Here it is high quality diamond knife instead of this phaco tip, but generally we use phaco tip. Then capsulotomy is done either with cystotome or with utrata forceps. Here it is being used utrata forceps. देखें circular rest हो रही है, बिल्कुल कितनी खूबसूरत जा रही है. Beautifully centered capsulorhexis is being done. So it is complete by now. Then hydrodissection is being done here, which, as I told you in diagram, to hydrate capsule and separate it from the rest of the lens. Once it is done completely, this phaco machine is disintegrating the nucleus and converted into small pieces, and they are sucked by the vacuum. And now with that of Simcoe irrigation aspiration cannula, we are removing the cortex. Look, beautifully cortex is removed. And after that, this is multifocal intraocular lens, which is put into injector, and then it is injected into the capsular bag and is centered, beautifully centered in the capsular bag. And best visual results, the patient will not be reading glasses either for distance as well as for near. And in the end we hydrate the wound and seal it without applying any sutures. So it is a sutureless, beautiful surgery. Now after surgery, what we see? This is the pupil, this is the edge of the anterior capsule or capsulorhexis, and this is the IOL in between the bag, and you don't see any suture here. That is the beauty of the PHACOEMULSIFICATIon. Now what are the advantages? First, it is sutureless, so it heals quickly. Surgery itself is a quick, less cost because no sutures are used, less complications because wound is small, rapid visual rehabilitation, reduce risk of wound related complication. जितना wound छोटा होगा इतनी complication कम होगी, and less astigmatism, much less astigmatism than standard extracapsular cataract extraction because there are no sutures. Sutures cause a lot of astigmatism. However, risks and complications are there with PHACO as well as extracapsular or intracapsular. Now, what are the risks? Risks or complication may be intraoperative, that is during surgery, early postoperative within first few days of surgery, or late postoperative after weeks or months or years after surgery. So, intraoperative क्या हो सकती हैं? Iris or corneal burn. This PHACO tip is very hot because of vibration. It generates heat, and that is cooled by the fluid passing through it. So, with inadvertent attaching or adhering the tip with the iris or corneal, you can lead to corneal burn, rare complication in the expert hands. Then the most serious complication during surgery is posterior capsular rent. When we were making gutter in the lens nucleus with the PHACO, if we go too deep due to inexperience, we can cut the posterior capsule, and if that happens, the nucleus may drop into the vitreous cavity and vitreous will prolapse through that rent into the anterior chamber and even out of the wound. That is a serious complication and that will need total vitrectomy. Then early postoperative complications are striate keratopathy or edema of the cornea, we will discuss soon. Leaking or rupture of the incision. If the wound was not tightly sealed with the hydrodissection or hydrodelineation or hydro position, as you saw at the end of video, then what will happen? Wound will leak out, fluid will come out, anterior chamber will collapse, and there is chance of entrance of infection from the cantava to this wound into the eye, and that may lead to endophthalmitis. So these are the complications which we will discuss soon. Late complication may be retinal detachment or tear if there was a rent in the posterior capsule, particularly if there was a rent. Cystic macular edema again is more common in cases of PC rent, and after cataract may occur in younger patients, less common in elder patients. Now coming to the discussion of one by one important these complications. This is a case of striate keratopathy. What happens that in hard cataract we may use high strength of high power of PHACOEMULSIFICATION in the anterior chamber or in the posterior chamber to disintegrate the nucleus. That will lead to heating or heat generation in the anterior chamber, and that can damage endothelial cells, and as a result of that they will not be able to dehydrate the cornea as it is their job through sodium potassium pH pump, so cornea will become edematous. However, with the treatment, this can recover in few days and patient will be okay. So this is striate corneal edema. The most serious complication is post-operative endophthalmitis. होता है कि हिस्ट्री क्या होती है, patient was fine in the evening or the next day after surgery and maybe coming with the next day or within first few weeks of surgery, first few weeks, days of surgery, less than 1 week, 5-6 दिन के अंदर आ जाएगा with the complaint that I have got blood vision, pain in the eye, and my eye is turning red. With this complaint, the patient will be there in your clinic, and if you see an examine, you will see ciliary congestion, cloudiness of the cornea may be there. You will see hypopyon in the anterior chamber, and on cerebellum you will see cells and flare and exudates in the anterior chamber, and you will not be able to see fundus grow through distant direct thermoscopy, isolate them from this pupillary area. That will indicate presence of pus in the vitreous cavity as well. And diagnosis is post-operative infective endophthalmitis. Very serious complication. It is a nightmare for the doctor as well as for the patient. So it should be treated intensively. First we take swab of the cantava for culture sensitivity and staining. Then we immediately treat it as an emergency measure. We use antibiotics in all routes, maybe intravenous antibiotics, both gram positive, gram negative. Augmentin दे सकते हैं इस patient को to cover 2 spectra orally. Then very important is that intravitreal उसमें क्या करते हैं, 3.5 millimeter away from this limbus we inject a combination of CVS, नाम याद रखिएगा, CVS एन एब्रिविएशन, C स्टैंड आपको याद करना है, CVS इज कार्डियोवास्कुलर सिस्टम। यहाँ क्या होगा, C इज फॉर cephalosporins, V is for vancomycin and S is for steroids. Cephalosporin to cover gram-negative spectrum, vancomycin very strong and anti-gram-positive bacteria, and steroids to reduce inflammation as a result of this infection. So all these will come together and combat these complications and will recover. Generally, patients recover in a day or two, but if there is no recovery, we can repeat injection on the next day and then go for vitrectomy. अगर रिकवर नहीं हो रही है, प्रोपेन कम नहीं हो रहा, अंदर आँख के अंदर से हेज नहीं जा रही विट्रियस से, देन गो फॉर विट्रेक्टमी, डोंट डिले इट बिकॉज देन इट विल बी डिफिकल्ट फॉर ट्रीट। विट्रेक्टमी करने से पेशेंट विल इम्प्रूव एंड वी विल इम्प्रूव। हाउएवर इफ पेशेंट कम विद लो सेट ग्रेड इन्फेक्शन आफ्टर वेरी very long time, maybe 2 to 3 weeks के बाद आता है, and vision is very low, maybe up to perception of light or less than that, then you can think of vitrectomy. And if vision is of low perception of light and eye is painful, then the treatment will be evisceration of the eye. However, once you have done this intravitreal injection of CVS, at the same time we give high concentrated topical antibiotics, that is moxifloxacin eye drops and tobramycin 1.5%, normally 0.3% होते हैं, या 1.5% 45 ड्रॉप देंगे 1 hourly. We will also give topical cycloplegics, atropine या cyclopentolate देंगे, so that there is reduced inflammation and people get dilated with no synechia. And apart from that, we can give oral NSAIDs. Generally, patient recover it in more than 90% of cases. So very serious complications याद रखिएगा, how patient reports and then how you evaluate and manage this patient. Some people, they have no apparent problem, eye is quite well formed anterior chamber, beautiful face, dense, clear vitreous, but patients have low vision after surgery. That is because of cystoid macular edema, which is more common in patients who have had some diabetic retinopathy or other macular condition abnormality before surgery, or they had rent during surgery, that will also lead to edema of the macula, that will keep vision at low level for quite some time until we treat it with naproxenic eye drops or treating the disease itself, so it will clear in due course. Another complication, that is a late complication, that may come across after weeks or months or even after a year or two. होता क्या है, residual cells at the equator, they start regenerating and forming this collagen material, because they turn into fibroblasts and lay out collagen on the back of this posterior capsule and causes opacification of the veil area. This is also known as after cataract. This is patient history क्या होती है, डॉक्टर साहब I was operated very well, I had good vision for several months or a year or more, but now vision is getting blurred, and on slit lamp examination you see this opacity on the back of the intraocular lens on the anterior capsule, on the posterior capsule of the lens. So it is very simple to treat it. Just we use Yag Laser Capsulotomy, focus this capsule with Yag and destroy or disrupt all this posterior capsule with Yag, make a beautiful opening, and through which patient will be able to see perfectly normal within a day or less than a day. So these are the complications, and this is how to manage them. Then retinal detachment, if that occurs, then that has to be treated properly by retinal detachment surgery. So you should remember all these things. This is a beautiful cover up of this cataract surgery and its complications. I will send you an assignment. You will complete it and send it back to my PA till 5 p.m. You are free to ask any questions related to it on WhatsApp, on my personal number, or by any other means on Facebook, etc. Looking forward to your questions and queries, and thank you very much, and regards. See you next week, and thank you.